there, if you haven't introduced yourselves, could you please, if you're on the phones?
This is Eileen Miller, and I'm in Red Lake from Red Lake Comprehensive Health Services, and I'm a CDE.
Okay.
Could that be Red Lake, Minnesota?
Red Lake, Minnesota. Yep.
Yeah, betcha.
Oh, yeah.
Hey, welcome.
Yeah, sure. Thank you.
So, today we're going to talk about how to have the talk and the multidisciplinary approach to the talk. And I really would like this to be interactive because I know that we all struggle with this and we all hopefully have come up with solutions or mechanisms to deal with it. And sharing that with each other, I think, will help us all move forward. We will take attendance again after the didactic. We'll have lots of times for questions. We don't have any formal case consultations today. However, we are happy to use any informal case consultations, especially around this topic. So hopefully you all have the presentation in front of you. The next 3 slides go over our disclaimer and what you need to do. You can receive CME or CEU credit, but we have to have your name and attendance in order to get that. Here's our disclosure and our accreditation. I have nothing to disclose. We do have a program with Molina Healthcare for those of you who participate in care with Molina patients, in that Molina will reimburse people who do case consultations $150 per consultation, and this can be either a prescriptive provider, a PA, nurse practitioner, a nurse, or a dietitian. So that's an opportunity to, one, get your case consulted on by our multifactorial team, as well as bring some more money into your programs.
Download it in clinic.
Okay, so the objectives of today are to understand the multifactorial aspects of obesity, understand the role of family, home, in preventing and treating, and understand the barriers in the clinical setting and how to break them down. So the main gist of today's talk is how to have the talk. And in order to know how to have the talk, we need to know why to have the talk. And this issue parallels that of smoking in the 70s and 80s. We realized in the 70s that tobacco use was a public health menace, but clinics did not really recognize their role in addressing that menace, so didn't talk about it. And then we learned over time that if you talked about it, the likelihood of having someone successfully quit or decrease their tobacco use went up significantly. Now we're facing the same situation. And there's lots of reasons why we don't talk about it. It's a lot harder conversation than having the smoking conversation. And there's a lot of other variables involved. But we'll move on to a little bit of epidemiology. Currently, obesity rates are about 18% in the United States. This is higher in certain populations, including Native Americans, Hispanics, and African Americans, probably those who are most vulnerable for complications of obesity. And there are a lot of reasons over time why this happened, and we have to put this into perspective in order to deal with the situation as it is today. This shows a cartoon of a playground with spider webs and ravens. I know ravens are important birds in some communities, but in this case they're invading the playground, probably waiting for that empty Frito-Lay bag to come by so they can get the last crumb. But currently, 92% of elementary schools do not provide daily physical education throughout the school year. At my kids' school, it's once a week.
Dr. Colleran, are you saying that in 92% of schools in the United States, PE has become for the birds?
Yes, Dr. Rifkin, I am saying that. And a lot of this has to do with funding cuts as well as things like No Child Left Behind, which we're slowly reversing. But we could actually get the kids to come clean up the playground and just have fresh fruits and vegetables lying around, and the birds would go away.
You'd hope that more would be raving for more physical activity and PE.
So those of you who don't know, Dr. Rifkin is our local community at, what do you call this, radio show Envision?
Yeah, Studio
Envision. We also know that, even worse, 6 out of kids don't participate in any kind of organized sport or physical activity outside of school. So if they're not getting it in school, they need to be getting it out of school, but they're not. And this, again, affects people of lower socioeconomic status, and that's due to a lot of reasons. It could be a single-parent home. The parent is working all the time. The kids just say, go home, lock the door, turn on the TV and wait till I get there. It could be that they don't have money to pay the registration fees, a variety of reasons. And these are all overcomable reasons. And we also know that 23% don't engage in any free time physical activity. So I call this free play. You just go out and play. You're not going to your sporting event. So the numbers are pretty dismal, and this has contributed significantly to increases in childhood obesity. Eating also has been a big impact. In 1980, about 50% of students reported eating green vegetables almost every day, which isn't that high. But now that number has dropped to about 30%. And these are replaced by processed and fast foods and those Frito-Lay chips. Milk consumption has decreased by 39% in about 2 decades, while fruit juices rose 54%, drinks rose 69%, and carbonated soda 137%. Again, contributing, at least milk has caloric and nutrition value. Another interesting factoid is that in 1970, about 25% of total food spending occurred in restaurants. In 1995, that number increased to 40% and has gone up further. We also know that when you eat at a restaurant, you eat almost twice as many calories. That Happy Meal is not so happy as compared to mom's food, less nutritious, more calories, and fewer nutrients. We also know that there's actually an increased medical risk with childhood obesity, and hospitalizations related to obesity in kids have more than tripled in the last several decades. So, to summarize the bad, we know that almost every aspect of the way we live has the potential to contribute to reduced activity among our children and worsening dietary habits. There's not one single thing that you can point out as the cause, but we can use single things to make baby steps to address the problem. So whose fault is this? Well, it's the kids' fault. It's the family's fault. It's the school, they got rid of physical education. It's the community, it's not safe. It's the government, they don't give enough money. It's the food industry. We know that's true. It's the doctor, it's the healthcare system, it's the dog. So all of these are true except for the dog. For if we had our dog and loved our dog and walked our dog or ran our dog 2 miles a day, we wouldn't have this problem and the dog would be in good shape. It's actually nobody's fault. It's everybody's fault, and it's everybody's responsibility. Dr. Phil. Is that the Dr. Phil? I pirated this.
Are those controversial figures in those?
Those are controversial figures.
Are they?
It's nobody's fault, but it's everybody's fault.
Especially those 3 people in that picture.
Oh, is that Lance Armstrong?
Yes, Lance Armstrong and the Schwarzeneggers.
Schwarzenegger?
Ex-Schwarzeneggers.
Okay. I didn't even know that. So who needs to be on the team? Patients, family, school, community, government, the food industry, doctor, the healthcare system, and of course the dog. Pest or power. So the role of the home and family component in battling this epidemic. We know that the family environment contributes significantly. And this is a lot to put on a family, but unfortunately it's a necessary thing that we need to do. So the availability of food that the kids get exposed to largely comes from the family. It can come from school programs. And schools are actually doing a pretty good job of trying to make them healthier in a lot of situations. Parent modeling, so what parents eat models what kids eat. And we have a lot of situations in this clinic where the parent says, well, I give my kid this special diet, but we all eat this regular food, which consists of McDonald's and potato chips and soda. So that doesn't really work because we model what our parents do. Food involvement, so how we talk about food with our kids, how we involve them in the process of shopping, of preparing food, et cetera, how we involve them in actually the meal by turning off the television, etc. Media exposure is a huge thing for kids, not only for food, but for everything, but they have figured it out with kids and eating to a way that you almost don't even know it's happening. And certainly how the parental feeding style or parental rules around eating are important. We also know that down on the bottom, the physical environment of the home is important. So if the TV is on all the time, if the kids are eating in front of the TV, that's not a good physical environment. If there are rules and restrictions as to what you can eat, that can be beneficial and it can be harmful. Again, parent modeling and support and encouragement, especially around healthy eating versus not healthy choices. So what about the clinic setting? Many studies have been done looking at this and found that currently only 20 to 50% of clinicians address the issue of obesity in their obese children at the time of the clinic visit. And there's lots of reasons for this, and we have heard many of them over the last few years. One is, that we haven't heard, but is true, is BMI is not being measured, and BMI percentile, which is what we use in kids, is not being measured. So if you don't measure it, you don't know it. And so if you don't know it, you can't talk about it. And it's actually surprising how somebody's body habitus can sort of look okay. And you can go under the impression of, well, they're big boned, but their BMI and their fat measurements are actually high. So it's important to measure it as a tool, not only to have that discussion, but to recognize healthy weight and to recognize even changes in BMI over time that may be progressing toward unhealthy rates. Lots of pediatric clinicians have not been trained in obesity. And therefore they have low self-efficacy in being able to do it. It's uncomfortable because you're putting them out there. And so it's kind of easier to avoid the discussion than have that discomfort level. Sometimes the patient and the family will become angry, and you have to be concerned that they won't come back to see you because you were, quote, judgmental, unquote. And there are limited tools and resources to address the problem. So recognizing the problem is one thing, but then coming up with a plan for the patient and the family can sometimes be very difficult depending on the home situation and the environment that they're living in. So why should we focus on the family first? Well, it's where most of our eating habits are learned and reinforced, or not reinforced for that matter. And it mediates the influence of the broader environment. So what we do at home passes on to what we do in a restaurant or at our friend's house or at school. And it sets the tone for eating behavior lifelong. There is a little bit of data that indicate the importance of focusing on the family environment. There's not a lot, only because there's not a lot out there. It's not that it isn't helpful. And common sense indicates that this is really important. So we often face discordant scenarios in the clinic or excuses. One, everybody in our family is big boned. Everybody. We all look like this, so it's okay. But one of the reasons we all look like this is because we all eat like this in our home. And so it's important to recognize that the family can work on being healthy. I don't know why he's different. Parents underestimate their kids' weight. They underestimate it by 30 to 50%. And so if you're underestimating it, you're not going to have a level of concern to address it. And then if somebody addresses it to you, you may become defensive and feel like you're being judged, or that the doctor or provider or whoever is wrong. And that may lead to avoidance of addressing the issue further. Big thing that we face is if there are separate households where the child lives and there are different approaches to how the child, to eating behaviors around that child. So if there's a divorce and they live with two different parents at different times of the day, one may be completely free for all, and that may be for a variety of reasons. That may have been part of why the divorce happened in the first place. That may have been to try to make the kid like the parent better. So he's the good parent, or she's the go-to parent, and the other parent may be very restrictive. These messages are very confusing to kids. There are other situations where the kids are cared for not in the primary household, but by a grandma's house or a daycare. And grandma grew up thinking, I was in the Depression, and anytime we get to eat, we need to eat, and we should eat whatever we want to eat if we can eat whatever we want to eat. So they just let him eat anything. It may be behavioral. Well, he won't calm down unless he has a Coke. Lots of different reasons. And we can help families overcome these one step at a time. But in order to do that, we all need to be on the same page. So one thing is getting the child and the family on the same page. And that can be done by having family meetings, especially if there's separate households or multiple people involved in the feeding behavior of the child. You can make contracts, etc., etc. And we should be promoting healthy lifestyle for the entire family. And it should be regardless of their current level of health, their location, or their genetics. So if Jim Bob is obese and John Boy, I'm dating myself to the Waltons, is thin, Jim Bob and John Boy should be eating the same meals, and they should be healthy meals. And so that's one message we need to get across. So how do we approach the problem? Here's some examples. Your child is fat. Your child is obese. Your child is at an unhealthy weight. If you do not do something, your child will get diabetes, heart disease, hypertension, and will die tomorrow. This is child abuse that you're doing. Yes, sir, Dan, Dr. Rifkin.
Kathleen, this slide...
These are not my approaches.
Okay, and the following is not mine either, but there is a cartoon here where there is the doctor wanting to talk about the elephant in the room.
Yeah.
Yes.
And the mother replying, isn't that a bit harsh?
Yes.
Yes.
Yes. However, I would pose that some of these are probably not the best approaches. Some of them are better, but there's one approach that's even worse than all of these. And what is it?
Not saying anything.
Not saying anything at all. Exactly.
Good point.
And so even if your approach is harsh, your child is fat, at least you've put it out there. They may not like it, they may not want to hear it, but it's there. And if you don't say anything, it's not there, it's not anywhere, and it's not on anybody's radar. But there are better ways to do this and less better ways to do this.
And Dr. Colleran,
Yes, Dr.
would it
Rifkin.
be acceptable to use the middle sentence?
Your child is at an unhealthy weight? Yes. That, I think, is the most acceptable of these.
We wouldn't edit that out of the soundtrack necessarily.
No. And there are other acceptable ways to do this.
Yes.
It's sort of the touchy-feely And you do get concerned that it's not going to be as effective as something more bold. But there are ways to do this, and we're going to discuss that in a little bit. And anybody's input, again, we're going to have a long discussion section after that. And if you don't contribute, you will be called on, because I've checked all of your names off. So how do you approach, actually, let me just step back. When do you approach the issue? And I actually think the issue needs to be approached at preconception. Because if you are conceived at a healthy weight with a healthy mother who has a healthy pregnancy, the risk of childhood obesity goes down significantly. The second time to approach it is after birth. And if you talk about the benefits of breastfeeding, when to introduce solid food, formula feeding, what kinds, what types, how much, early on, they're going to do a lot better. And then it is any time you start having child care visits. I think it's probably should be part of the vital sign. I guess it kind of is. But we don't address it. So it can be your child is at a really healthy weight. That is awesome. If they're not at a healthy weight, then you talk, then you have the conversation.
So
yes.
Question. So when you looked at the efficacy of the providers and not doing BMIs, I think this, when you raise the point of having that discussion after birth, reminding providers, and at least we should start teaching them, that they can start assessing BMI at birth now. It's been available to us for the last 6 years. But I guess we haven't reached that 10 to 14 year point of adoption yet. So we're only 50% of the way there. But trying to get people to use the World Health Organization chart so that you can actually start assessing BMI, body composition earlier.
Thank you. That was Dr. Kristen Bennett. But that's a really important point. You can get those charts on our website or from the World Health Organization. They're fairly easy to use. It's just like the height and weight chart. It's just the BMI and BMI percentile. And there's no reason not to have the talk when everything is okay, because everything is okay. And if the family knows that you're on board and this is what's important to you as far as their healthcare provider, then they're going to feel a lot more comfortable if a problem starts to develop, I think.
And they'll be less likely to second guess themselves when Granny says, "Oh, they're too thin."
Yeah.
Yes.
Because they've been having that positively reinforced,
Mm-hmm.
you know, as they go to their visits, their regular PCP visits.
Mm-hmm.
But my doctor says.
Right. And so that is a big problem, the family conflict. When they go to Grandma's house, Grandma criticizes the daughter-in-law for not feeding the kids. They're starving, they're too skinny, when they're normal. And so that's a common scenario, and the daughter-in-law's got to get tough, or the son-in-law, or the son or the daughter. So anticipate resistance. And I mentioned everyone in our families like this. This is our normal. Now, because this is such a large problem, a lot of, since 30% of, or almost 50% of adults are obese or overweight, it does look normal, but it's not. We just have a slow metabolism. Well, his football coach thinks he's fine. In fact, he wants him to gain more weight because he's going to be a linebacker. And then there's the more severe things like, who are you to judge? How dare you? We're not coming back here. Those are difficult situations, but I think you can try to anticipate who's going to maybe take that approach and then use your more soft approach to deal with them. So again, there's lots of ways to do this. You can confront them. Your child's fat, overweight, obese. Your child's going to get diabetes, hypertension, blah, 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 blah. Or you can take the softer approach. I don't have this on here, but we'll get to that in a minute. I'm going to talk about in a minute using the BMI chart as your tool for the clinic visit. Not just to go into the electronic medical record, but actually to interact with the patient and the family. So you can just not talk about obesity and weight. You can talk about healthy eating, a healthy home environment, a healthy school environment, healthy physical activity, and use those as health indicators. You're kind of avoiding the whole conversation, yet you're trying to ask them to do one or two things that are going to improve their health. And this is where you can use our Zip to Health resource, where they can tell me the zip code again and what it stands for? Someone.
75210.
75210.
Eat breakfast 7 days a week.
Eat breakfast 7 days a week.
At least 5 servings of fruits and vegetables. Not more than 2 hours of screen time. 1 hour of physical activity. And no sweetened beverages.
So you can...
There will be a quiz at the end.
You can download this also from our website. Show it to the patient and the family. How about if you pick one of these to work on?
And we do have a shared encounter form that goes along with that promotion, so also on our website.
So this can't be about you telling them what to do. It's got to be everybody getting on board. And then you can try to identify resources that they can use so they can implement these things, including resources at the school, in the community, including growers markets, accessible groceries, alternatives if they don't have access to fresh fruits and vegetables, such as frozen or dried. We like to avoid canned products because they contain a lot of sugar or salt, but you can have the family rinse it with water and get rid of a lot of that stuff. And any accessibility to physical activity. We have created some resource guides for some of our communities in New Mexico that actually list all of these things. They tell you about discounted rates for soccer programs, walking trails, other free physical activity, ways to get groceries, etc. And so some of these guides may exist in your communities, but again, you can find the ones that we have used on our website, which is what?
Which is envisionnm.org. And if you scroll down on the left-hand side to under Special Projects, all this information that we just referred to is under Special Projects, Zip to Health.
And if your community would like to consider trying to create one of these guides, we can help facilitate that or have a discussion about how to do that.
And currently we have in Albuquerque, Gallup, Farmington, Las Cruces, and Tucumcari.
And we're developing one in Roswell as
and Ruidoso.
And Ruidoso. They're awesome. It's a small guide. It just gives you all of the information that you need in your community. I hope it's part of relocation packages.
That would be neat.
So another approach is using the growth chart and the BMI chart, because a picture is worth 1,000 words. And you can use this to promote the positive as well as where changes need to take place. And usually you can look at the height, and usually they're at the 50th percentile or above, because we know childhood obesity increases growth early and then it arrests it. So you can use that if they want to be a basketball player, that if they have to be healthier in order to grow to their full potential. You can use the weight, and if it's out of the range of the 5th to 95th percentile, then you can show them that this is where they're at and this is where I would like them to be. So let's make some small steps to help them get there. You don't have to say fat, you don't have to say obese. You can use the BMI with the same information. You can also use that for accelerating weight, height, and BMI. So if they're starting at the 10th percentile and they're progressing up to the 95th percentile over a year or two, that's a warning sign. That's a warning sign that they may soon get out of the 95th percentile and into the obese range. So it's a great tool. It just says what it is. And then you can use it if they're making healthy changes to track those and to reward them. So it's really all about where they should be. It's not a punishment. And then it's saying, how can we help you get there by doing these other things that we've just spoken about? Focusing on the positive. What's your favorite green vegetable? Broccoli? Gummy bears? So what can we do so that you can eat that 3 to 5 times a week? What's your favorite fruit? What's your favorite thing to do for fun? That's not an Xbox.
But they do have Xbox with.
They do.
With the physical act, and I went to one of the conferences. That's what we did the evening before. Is we all had to do the circuit training on that. That is some serious exercise.
Yeah, they do. And so you can make an agreement. How about if you do 30 minutes of Xbox? What do they call it?
3 360.
Yeah.
360.
And then you can do 30 minutes of
Yeah.
that game where you kill people and monsters and stuff. That's not bad. I mean, that would be, and that's their 1 hour, one of their 2 hours. So, negotiate. And then, make it a family affair. Find out what can the family do together so they're all healthy. So we're not just telling Jim Bob to go run around the block and let John Boy sit there and play on the Xbox. It's something everyone can do. Beth Goins, our cardiologist who's not here, she has powerhouse cleaning. So the whole family spends 20 minutes and they get the entire, well, it's probably 30 minutes, get the entire house clean, and then they're done for the week. It does take baby steps. You can't say, okay, you need to lose weight, you need to exercise, go. You have to give them ideas, you have to use small things they can accomplish and be successful with, understanding that there may be setbacks. And so demonstrate successes. So you can focus on weight, you can focus on BMI, you can focus on blood pressure, especially if it's elevated, which we know is elevated in about 30% of kids who are overweight and obese. But lowering that, it's something that you can demonstrate with a picture. You can track it on a graph. You can demonstrate benefits in lipids, which actually come down pretty quickly, especially triglycerides. And you can demonstrate how do you feel? Do you feel better? Do you feel like you're more active? Do you feel like you're getting better sleep? Do you feel like you're not being bullied as much? All those sorts of things. Motivational interviewing is one of our mantras, and it's a huge key to success in this type of an intervention. You have to have the patient and the family set the agenda. If they're not there, if they get angry with you about talking about it, just offer them the opportunity to think about it and maybe talk about it the next session. Give them some material that they can look at for healthy living and eating. And then when they come back, ask permission. Can we talk about what you've been doing to be healthy? Again, trying to get them on the same page, moving them from complete resistance to maybe being a little bit contemplative and moving forward with small things, very small things. You can't just accomplish this in one visit. I'm going to talk group problem solving. So get the whole family to think about how can we overcome this barrier or that barrier? How can we actually deal with them not being involved in physical activity or the fact that they'll only eat Cheetos? Again, baby steps. Peer pressure. There are programs around the country where peers engage and they have conversations, and so you can enroll in a peer-peer program and talk about this. And I'm going to talk about group visits in a second. But motivational interviewing, getting the family and the patient to set the agenda, getting them on the same page, addressing issues, barriers, and problem solving with them to overcome those.
And the next session of COMM-TC on the 19th is exactly that.
Okay, so I hope you heard that. So we're doing an update on motivational interviewing as it relates to childhood obesity, and so that would be an excellent session. Other clinical approaches, doing follow-up phone calls and or support. I don't know if this is on here, but certainly the team approach to care. So asking the nurse or the MA or somebody else in the clinic to do a follow-up phone call and say, how's it going? It doesn't have to be long. It can be 3 minutes. And if they're not doing so well, a few tips. Handouts at sessions, suggestions, individual suggestions to the family is really important. As I mentioned, just saying lose weight and be active doesn't work. So find out what the family can do. They can take a walk, they can have a hula hoop contest, they can jump rope, they can dance, they can do Xbox physical activity. Cable and Netflix has bunches of exercise shows, including Zumba and hip hop. And there's community-based activities as well. And again, if you have a resource guide, you can get easy access to them. The key is to have something to deliver to the family once you've had the talk. team approach, Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So what about group clinics? These work best for adolescents, young adults, or teenagers, only because they're of the maturity level that they can have that discussion with each other. And it provides significant education and counseling. You have on the team a clinician, usually a dietitian, a psychiatrist or psychologist, somebody who can facilitate the group. And the likely that the kids will have very similar behavioral issues, needs, barriers, constraints, etc. Nobody gets signaled out in this type of a setting. Everyone's on common ground. There is peer pressure with the others in the group to succeed. It does require motivated patients and families, and that does take some time. These can be short, 4 to 6 weeks, often followed up by monthly visits for 6 months. And again, you need a team. Usually it works best with small groups, 8 to 10 patients and their families. And there are sessions for everyone, and then breakout sessions where the adolescents go to one room and the parents go to another, and they brainstorm separately and then come back together. You can do a group activity all together to demonstrate that. Also can incorporate a healthy meal into the program, rewards or incentives, whether it's like a pedometer or an app or something, food coupons, etc. So, in conclusion, the family environment and parenting behaviors are likely the most critically important aspect of childhood obesity. And we don't have a really good understanding of that, but we are certainly working on it. And working on things around eating behaviors, physical activity habits, and the risk of childhood and adult overweight and obesity. So, discussion questions are: what are your experiences? What have you faced that's adversarial, and how have you overcome it? And what tools do you have for the rest of the group? What would work in your setting if you were going to implement something new, and how would you move that forward? And again, barriers, resources, and other ideas that you may or may not have. Before we get to your responses, which I know you're avidly thinking about right now, I would like to get attendance for anyone who has not yet signed on, or who has not yet introduced themselves but has signed on.
This is Donna Lochner in Albuquerque.
Hi, Donna. Anybody else? I thought there was one or two more. Okay. Remember, if you want to get CME or CEU credit, we do need to have your name. So I'd like to open it up for general questions, and again, any of these questions if you can't think of a general one.
This is Gwen Bounds. I'm the WIC Nutrition Services Manager for the WIC program in New Mexico. And Donna Lochner and I have actually started to have some statewide meetings or trainings on the WHO growth chart and also the CDC growth chart, where we're using the BMI calculator, and that's really helping with the understanding of just the overweight problem. Donna can probably speak to this a little bit more than I can, but she really talks about how it's so important, and it is our responsibility as WIC staff to bring this to the parents if a child is overweight or even underweight. And we do have participant-centered education, which involves motivational interviewing. So all of that is really helping us discuss with the parent, or when we do the growth charts, the parents will ask questions, so the parents are more in control.
So thank you, Gwen. Those are sessions for the parents specifically.
But actually, when the child or the person that is being certified for the program, the growth charts are used. We also have a gestational diabetes program with UNM. It's a collaborative, and we talk about BMI and making sure that moms, have a healthy pregnancy, and we can discuss that even at the postpartum sessions also.
That's great. Thank you for sharing. So obesity begins before birth.
Yes, that's what we're trying to put forth.
Great. Other programs or resources that people are using that they've found to be effective?
Hi, this is Molly Lee. As I went to tell you that I was here, I pushed the wrong button and hung up on you guys.
Oh.
I'm here in Frisco, Colorado. I'm a nurse practitioner, and we have implemented our health educators. We call them health coaches, and we do lots of follow-up phone calls. We set goals with the health coaches will set goals with the family, and then the health coach will follow up and see how they're doing on those goals and modify them or augment them as appropriate. But that plus the motivational interviewing seems to be more successful than the eat less, exercise more answer that we tried for a while.
Great. And health coaches are a very cost-effective way to address this.
Yes.
And they're usually
That's
culturally appropriate, etc.,
Yep.
literacy appropriate. So that's great. Anybody want to describe any obstacles or barriers that you've faced in trying to move your efforts forward, whether it's with an individual or a family or a community?
This is Glenda Kanaka. And I want to share you already mentioned that the importance of the whole community working together, but here at the Prevention Research Center, we work with the communities. And one of the trainings we do, we train them on how to measure children and BMI. We work a lot with Head Start, and they are required. Most Head Start programs are required to have BMI. So when we do our training at the end, and one of the questions that I fear the most, but it happens every single time we do a training, they ask, well, the big question is how do we address that to the parent and to the family? How do we tell them? But they even have their suggestions on how to do it. But one thing that they have found is a big obstacle is they don't feel they have the support from the healthcare provider in the community. They said, we tell the families your child is overweight, and we show them the chart and the BMI chart, and then they tell us, I went to the healthcare provider, to the physician, to the pediatrician, and they didn't say that. So when we're all thinking about, do we bring up this subject, do we yes or no, just remember that the parent most probably already heard it somewhere. And that even if they don't mention it to you as a healthcare provider, they're waiting to hear it from you. I don't know, because that's one of the, and I don't know what to answer to these community members, because at Head Start, it's different. They have to relate all this results to the families. They talk about all goals. So health is one of them, and BMI is one of them. They share that with the parent. But this is a teacher, a Head Start teacher. What do you know? The physician is the one that really knows, but they don't tell me anything. I even mention it to them. Some of these teachers say, I mentioned to my pediatrician, and they say, no, they're fine. They're okay. So the importance of supporting the rest of the community that is already doing that.
That is a great, big, huge, ginormous barrier. And we've heard that before. And yeah, what do you do? And so I mentioned in the beginning that only 20 to 50% of clinics were doing BMI measurements. So again, if you don't have the information, you don't know what it is. And that an additional, or the same, probably 20 to 30 don't even address the issue. And so when you're getting that, discrepant information, one, you're probably going to listen to the person who's going to give you the most favorable information, even if it's not the right information. And yeah, two, the great, powerful doctor knows it all. And why would you listen to the lowly teacher, so to speak? I'm being sarcastic here. And unfortunately, as clinicians, we have not done very good jobs in prevention and addressing social behavioral issues. And sometimes I wonder if that should be given, that responsibility should be given to somebody else, like the nurse in the clinic, or the health coach, or the nutritionist, or the teacher. But yeah, we all have to be on the same page, and that's a big barrier. And I think, you know, it's just it's education, education, education. And sometimes if you, the teacher, are going to reach out to the clinician and say, you know, I'm concerned about Joey because his weight is going up and he's not, and his height isn't going up, the clinician may do one of two things. They may say, thank you, I will look into it. Or they may say, what do you know? Which is not effective. But it's, yeah, really trying to establish these teams that involve WIC, Head Start, school, community, family, etc. And I think we just have to try to overcome that one step at a time. I think in the younger generation, we're doing a better job of teaching them how to be on a team, but we'll have to see. And has anybody found a way to overcome that specific obstacle? One thing that we're doing a project in Roswell, and we're going to partner the school-based health nurses with the one of the largest pediatric medical clinics, with the CMS caseworkers with DOH, and we're going to create this community resource, and we're going to all convene in this format here with telehealth to try to really get everybody on the same page. And see if that leads to expansion. And hopefully we can get rid of some of those barriers of the top-down model, which is kind of what you're describing. So we'll let you know. But thank you for sharing.
Thank you. I have something. This is Stacy Briscoe from the Reno Sparks Indian Colony. I'm a dietitian here at the Tribal Health Center. Mm-hmm. And, you know, I'd be interested in some feedback because I have one obstacle that I think is really challenging, and it concerns free access to food. A lot of times, I mean, we all know that intervention early is obviously important. You know, by 4 years, obesity is just, we want to make sure it's stopped soon, right? So, but then I'll have parents that have their children coming in who have free access to food and just kind of feed indiscriminately without any sort of checking to portions and quality and all of that. So I guess my question is, you know, what is the communal opinion on, you know, the education of discipline for access to food? Because I think at 4 years old, they don't necessarily have the skills yet to determine that, okay, I've had enough Cheetos, it's time to not have any more Cheetos, you know. But I see oftentimes that kids are just allowed free access to whatever in whatever quantity, which, you know, we all support free access, but at the same time it can be very detrimental. So I just wanted to see if there's any input on ways to manage the free access problem and thoughts on the discipline aspect of the intake problems that we see.
Okay, thank you. So I'm just to clarify, by free access, are you talking about commodity foods?
No, I mean, for example, I'll have a kid who is able just to go up to the cabinet, or the pantry, or the fridge and just get whatever out whenever. And
okay,
the BMI is over 97, and it's just a problem, and it's not generally, they're not going to get carrots and celery. I mean, it's not
right.
Good stuff.
And so that's a family parenting, or whoever the caretaker is, item. And it's, the easiest thing is don't have those foods around. Instead, have as many carrots and celery sticks as you want. So a 4-year-old, can't discriminate, and they probably shouldn't be allowed to try to discriminate. And those foods can be stored in a place where they can't have ready or open access, and it can be a treat. That's what it should be, is a treat. We're not going to get away from not giving kids Red Hot Cheetos, but we can get away from using it as free access. And so another thing I didn't discuss is home visits. And these are usually done by health coaches who, again, have the cultural, language, health literacy of the patients and the families. And they can offer to go do a home visit and see what's there and brainstorm with how to really make it healthier. And you have community health representatives up there, so that would be a potential option, depending on, I don't know what the setting is. So one, limiting those types of foods. Two, certainly the small bags are better than the big bags, because a small bag is one serving. It's probably more costly, so that's another issue. But portion size is important. And for meals, we model the 50-50 plate. And you can actually have the kids make their own 50-50 plate. They can paint on it, paint the fruits and the veggies and the rice and the meat. But yeah, it's a big problem. So if it's there, they're going to eat it. So the one thing is not to have it there, not to have it accessible, except under special circumstances. It's a treat. And not to have mom and dad just readily eating it as well, because again, we model what our parents do. One of the reasons we're starting to get rid of vending machines in schools is because of that it's not free access, but it's open access to things that are unhealthy. But does anybody else have any comments to share with Stacy?
I actually think it's a really good, and I don't have any answers, but I think it does describe a pattern that I see a lot of times in families, which is that parents don't necessarily put any boundaries around when their kids eat, and sometimes they don't put any boundaries around much of anything. And I don't really know, I'm not really sure how to start with either empowering parents to create boundaries, or even necessarily communicating that that's really something that, at least in my biases, they should do. I think that's kind of a pervasive sort of dynamic that it isn't just about what do you buy and what do you keep in the house. It's kind of a basic understanding about how you relate to these little people.
Right, so avoidance isn't really the only answer. It's best setting up boundaries and having kids become accountable to that. And that's important for development into adulthood and being a responsible human being. So setting up boundaries, and maybe, Dan, can you speak to this at all?
Setting up boundaries around...
So around everything. How long you play on your pod. We call it podding. We've made a new verb at my house. How much physical activity you do. And when can you start setting those boundaries as far as developmental stages?
Well, I think the boundaries can be set around many of the things that you've talked about. You're right. I think one way to do it is to build it into contingencies so that screen time can be earned as a contingent upon the appropriate and needed behaviors. Appropriate behaviors that are needed for the child's responsibility taking and what the family is accomplishing. So there can be screen time after chores are done. There can be screen time after homework is done. Yeah. Okay. Of course, chores can be start in with the chores earlier on. That could even be started before homework is gotten in school. Say by 5 years old, kindergarten age. Okay. As far as by what age developmentally is it appropriate, I think of the Ericksonian stages and how latency age, early latency age, is marked by the great interest in following rules and making accomplishments. So I think that, and being part of a group of people that do that is very important. So I think to have that implemented by first grade, even starting by kindergarten, is something that can be done. Screen time isn't the only thing to build into the contingencies. There can be, you mentioned, treats, foods that would be special. Well, that can be built into following the diet that the family has, I suppose, without using the word diet, for example. So I think that can help build some boundaries and some limits on behaviors and including eating.
So when you stepped out, we had a comment from Stacy in Reno about open or free access to food. So there's a big bag of Cheetos. Mom is in the other room or maybe in the same room, and kids can just go walk up and start eating whatever they want, whenever they want, with no boundaries. And how do we deal with that? And of course, I came up with the prohibitive approach of don't buy those things or lock them away. And then Jane appropriately said, how do we set boundaries? So Dan responded. So I don't know if you have any
that's great. And I think the key message there to me is that the parent is the parent. And the parent needs to be reminded that they are in charge of the environment that they brought their child into, and that it is their job and responsibility and their right to take control of that environment and make it the best place for that child to grow up. One of the talks that we've had several times in P&T is the Claire Davis experiment, which happened in Canada, and I've shared that several times with many of you when we talk about toddlers, because this was a experiment that was done in the 1920s in an orphanage. And she was a pediatrician, and there were many complaints about prescriptive feeding, because that was very much the thing in the 20s and 30s and 40s and 50s in terms of, wanting to, you must feed your child this much and only this, and, And so in that set of experiments, she followed a group of students or young children who were living in, the toddlers who were living in this orphanage, and they gave them free access to food and monitored their growth and intake and food behaviors. And lo and behold, guess what? These kids were just fine. They grew well. They weren't overweight. They weren't underweight. But the trick is that the environment included only those things that were going to be beneficial to the children. So there was no way that they could make a bad choice about their food. Now, it doesn't mean food was left out all the time. It meant that when it's time for breakfast, choices were out there. When it was time for a snack, there were choices. When it was time for lunch, there were choices. So I think the key there is, again, taking control of that environment and making it an environment where everybody wins. There's no bad decision at that point. You're not going to fight over that you didn't drink your milk at lunch. Milk was available. We normally serve milk at lunch. Today you didn't want to drink it. Fine. I realize that's going to be fine. We're going to put all the food away, and in a couple of hours, we're going to have a snack. And I am, again, as the parent, going to be in charge of what that snack looks like. You can choose to either eat it or not. However, that's what it is. We're not going to give it any more importance than it needs to have, in that moment. So I think that fits with everything else. But I think parents generally, I mean, just hanging about with the parents of friends of ours and our own children, is that there seems to be this hesitancy to take charge of our environment and set boundaries and limits around a lot of things, whether it's people's cell phones or their, TV time, or what friends they hang out with, or how late they stay out at night, or whatever. And I was, when I work with parents of young children, I'm like, it's going to be a whole lot easier if we set the expectation that I'm the one who controls the environment to some extent now than when they're 16 and you decide you want to start that conversation. Because it's probably not going to go very well. It's kind of like having the discussion with the family from birth about this is what the growth chart looks like. So they expect every time they show up for a well child visit that you're going to get to talk about that child's growth. So it's not going to be a surprise if there's a change and they raise a question about the child's change in growth, one way or the other.
So giving the parent permission to be a parent, which sounds kind of stupid, but I think it's important, because we are much more boundaryless, I think, in today's world than we have been. And using motivational interviewing to guide them to actually being the parent and setting boundaries. Recognizing that it's sometimes hard. There might be a fit. There might be a tantrum.
There will be a
fit. There will be.
And there will be doors slammed and things thrown and walls colored on and dishes dropped to the floor.
But the earlier in life you can start having that, the better. It doesn't mean that you can't do it later. It's harder, as you mentioned, but it's still doable. So if they're 15, use the driver's license. So, not a lot of answers, but I hope that was somewhat helpful. And good luck.
I'd want to add also that while the example I gave with doing chores, for example, involve recruiting the children when they're by the preschool or entering latency time, I think when it comes to foods, this can be started much earlier.
Yes.
Children can get used to the idea of their 5 servings of fruit and vegetables every day. If they're wanting to get up into the cupboards and get a treat, the message is that's after your 5 fruits and vegetables, and I will give that to you as your parent after you've had those. So let's see how your day goes.
Yeah.
And we'll see about that dessert. As far as boundaries, these can be very physical boundaries with putting foods away out of the reach of younger children. Maybe a padlock with a combination for older children. But I think that
I always wondered how ethical that was.
Ethical padlocks?
On the Cheetos,
yes. I've thought about it when this is Stacy, the dietitian. I thought about recommending the padlock on the fridge, but it seems slightly unethical.
Yeah, well, on the fridge it would be, but with more selectively with particular foods that we know are not healthy for a child to be eating on a regular basis, I think it's reasonable and logical to get those foods out of the mainstream of the food-seeking routes.
And certainly padlocks do get used in certain circumstances. So in certain disorders, Prader-Willi being the one people think about, then it is very ethical to do that.
Sure.
Because you're keeping someone from hurting themselves. And the issue there is that they have no ability to recognize satiety, so they can actually eat themselves to death, literally, in an episode. So that's why you do that. And I guess if you think a child needs that kind of restriction, then you would talk about that with whoever you're working with, provider, and I would certainly want a Dr. Dan in the room making those kinds of decisions about whether or not that was the kind of control that was necessary. But I don't know what's in the fridge that you're locking up. But again, I think the easiest thing is to control what's in the fridge so it doesn't matter what you get when you get out of there. That being said, large children can eat large quantities of very good things, and it can still create a problem. So, that's certainly another discussion.
You could have the snack bin that you pull out after the
5 servings of fruits
have been right, or whatever it is, and then you let them pick anything they want from that bin. You bought the bin, so you know what's in it. One thing, yeah. And so that'd be kind of a cool way. Here comes the bin. And if you didn't do yours, you don't get anything from the bin, and that feels kind of bad. But you may think the next time that if I want to get my bin food,
so
separate it from
a little word of caution. There's some good work. I think it's the University of Pennsylvania, Leanne Birch, she's a psychologist, not a dietitian, who does work around children's feeding issues. And so there is some danger to elevating the bin food to something of importance that it's not. And so she has some very classic research that's taped that you can watch if you ever get a chance to take a look at that. Putting toddlers or kindergarten students in a room with, here's your lunch, and it's lunchtime. It's a very well planned lunch, proportional for what they're supposed to eat, and they've got a big jar of goldfish with a big scoop, and you can't have the goldfish until the bell rings. And so the kids are eating their lunch and visiting. As soon as the bell rings, they reach in, and kids will take large quantities of goldfish because goldfish has now been elevated to the level of some importance. If you do the same experiment where he said you can't have any, there's some goldfish here, but you have your lunch, and if you feel like you need a little supplement to your lunch, feel free to use a little scooper and get some goldfish. When you look at the quantities of goldfish consumed ad lib when children are presented with a very reasonable lunch, it's almost nothing. You'll have kids take a few because they like goldfish, or it's kind of fun to add goldfish to the top of their pizza or whatever, but they don't go after it where you see kids just diving when the bell rings into this bin of goldfish and putting a cup and a half of goldfish on top of their lunch plate. So it's kind of an interesting experiment. Anyway.
Great, thank you.
More information than you probably wanted, Stacy, for that question.
No, but it's all, I guess my main thing has been that I'm just I've been wrestling with whether, we need to be teaching our children about what satiety is, or if they just develop it naturally. And more I've been trying to get parents to say, well, you have to model, the right behavior, that, okay, you've had enough, not necessarily telling them that, but because a lot of these kids just don't have any concept of satiety, and maybe they're too young, they need to be taught, but we do need to be a little more disciplined about it, I think. So I really appreciate all your input, though. Thank you.
Yeah, and I think that you bring up a good point, and I guess I would argue that Dr. Colleran was talking about preconception work with families and right after birth. Unless a child has some medical issue, they're all born with internal satiety. It's already there. And you preserve that by breastfeeding infants and helping moms negotiate the cues that an infant gives them in terms of whether they're hungry, whether they're tired, whether they need their diaper changed, whether they just want to be held, whether they're in too bright a light. But some of that is preserving the self-regulatory mechanisms that children are born with. And I think we do a very poor job of preserving those. And so then what we're trying to do later then is try to remind that child that they were given some of those gifts to begin with, and we have to remind them that they're still there, and you have to take time out to go back to that. And as adults, we have the same problem. It's 12 o'clock, I got to eat lunch, because if I don't eat now, I have meetings until 6. I might not be hungry at 12 o'clock, I was hungry at 11. You got to give yourself permission to eat your lunch at 11 when you wanted it. Or eat your dinner at 4:30 if that's when you wanted it, But that makes it a little bit harder. But if you're working with a young child, recognizing that your child has that pattern, there are some things you can do in a flexible setting to make it possible to preserve that. Dad doesn't get home till 7 o'clock. It's probably not reasonable to make that 4-year-old wait till 7 o'clock to eat dinner. So you're going to have to figure out how to negotiate some of that in the work that we do with families. But I think that self-regulatory thing is really, really important, and it's certainly difficult to re-engage that once kids get older because they've learned to turn it off.
And there are certain foods that turn it off, the trans fats especially, sugar, processed sugar, even diet sodas actually increase your sensation of hunger. So, so society has contributed to that as well. Yeah.
Well, okay, I'll make this conversation go even longer. Stacey, this is Kirsten Wantz. I'm a renal dietitian, and I feel for you because I have this problem all the time. And I have no problem telling the parents that you can explain to your child all you want what a healthy diet is, but if they're 5, they're going to give in to temptation. So it's your responsibility to have healthy things for them to give into. And I do recommend things like only have healthy foods available in the fridge that the child could reach. If you have older kids that are going to be getting the food down and eating it in front of the other child, you might have to lock up junk food. My favorite thing to tell them is just don't have it in your home. If you guys like chips, you can walk as a family after dinner down to the market and get a snack bag each, walk back home, and that's what you do. And if they're willing to do that, then you can start there. But I think it's important to just address it because the parents may not really understand that. And it also helps them bring to you obstacles. Maybe it's their teenager that's buying all the chips, or maybe it's dad that's doing it. And then you can kind of work with the parent one-on-one to eliminate that one obstacle.
Yeah, so I think that's a great, don't assume that they know.
Don't assume anything.
One scenario we had here was the mom had Gatorade in the bottle. And the mom said, well, it's a sports drink and it's cheaper than whatever's supposed to be in the bottle. And so the mom had no idea that the sports drink is not really healthy. It's mostly sugar. But she thought she was doing a good thing for the child, and she could afford it. So yeah, never make assumptions that the family knows, because again, the media will try to tell you otherwise. And if they say, I already know all that, then apologize.
Yeah. Yeah, I do start though, well, you probably already know this, but blah, blah, blah.
Yeah.
So that I don't come off some snooty person. But
No, thank you. I appreciate it.
There's a couple of ways you could say that too. Is what do you know about sports drinks, or how do you feel about the sports drinks? Using those what, how, tell me. Those are kind of the open-ended questions.
Exactly. That's a great point.
This is Eileen up in Red Lake, and our dietitian in her room has empty bottles that with the amount of sugar that comes in those. And so she puts the sports drinks and the juice right in there with the sodas. And a lot of time the parents or the kids will just pick them up and they'll just be amazed that there's that much sugar in Gatorade.
That's
it's it's an easy way.
That's a great tool too. So you can do that with lard or fat or butter. It's more disgusting, but
true.
That's a great resource. Thank you for sharing. Other comments or questions? Okay, well, if you have any comments or want to give any feedback to the session, we'd love to hear from anybody. You can send by email. Our next conference will be on April the 19th, and we will be doing motivational interviewing. And Carol's doing that. Carol Conley, our motivational interviewing expert. So please sign back on. Please consider case consultations, formal or informal. The forms to complete those are on the website. And we'd love to have discussions around actual cases. So please feel free to do that. And again, if you have any comments, just let us know. Otherwise, thank you and have a great weekend.
Thank you.